morning, everyone. So today I'll be talking about my new techniques for managing iridodialysis and scleral fixated IOL. Slide, how did it change? So the current techniques are cumbersome, involving peritomies, Hoffman's pocket, scleral flaps, and a couple of sclerotomies to interiorize and exteriorize the suture to knots. So this is our technique of iridodialysis. So this is a traumatic cataract with 3 to 4 clock hours of iridodialysis that we see. So after staining, using an iris hook, the iridodialysis is kept at bay, and then a rhexis is done and regular phacoemulsification was done. Fortunately, the bag was stronger, so we didn't need to have any CTR placed. So the IOL was placed. After this, the regular HPMC was washed, and a combination of dispersive and cohesive viscoelastic is injected into the eye to flatten the iris. In this stage, it is very important to use that viscoelastic than HPMC, because HPMC, the iris tends to roll down. So we want it to be flat. Then the iridodialysis area is marked and the points of anchorage is identified. Moving the conjunctiva radially, a spatulated needle attached to 70-proline is passed ab externo into the eye, and using a microforceps, the peripheral iris is held. It is pierced through the peripheral iris, and the same needle is exteriorized through the clear corneal incision that we made for phaco. And with the same needle, a U-turn is made outside, and the needle is introduced into the eye. In similar fashion, the peripheral iris, which needs to be anchored, is held, and by moving the conjunctiva radially towards the limbus, at the level of iris plane, the needle is exteriorized ab interno. So now you have a suture loop inside the eye. So both the sutures on the exterior are pulled till the approximation is achieved. Once the approximation is achieved, the first flange, the first suture is trimmed and flanged about 1.5 millimeters, and the other suture end is pulled so as to bury the first flange below the conjunctiva and T-knots. Similarly, once the approximation is checked again it is trimmed, flanged and buried, and the conjunctiva is ironed out, so you can see the 2 points of the flanges, whereas the conjunctival opening is much posterior. So it's a very simple way of doing iridodialysis repair. The instruments that we need is a spatulated needle attached to a 670-proline suture, a portable cautery. The advantages of this technique over the current techniques is no peritomy, easier and quicker learning curve, less time consuming, no flaps or pockets required. So these are post-operative one-day pictures of the iridodialysis repair. So we've done so far 8 cases in the last 3 years, and we've had no complications so far. So this is the second innovation inspired from Yamane and Canabrava's technique. We did our own flanged SFIOL, where we use the same specially designed spatulated needle. Is passed.
The needles are docked into an
It is
irrigating
passed.
cannula
It is
and
using an AC
externalized
maintainer.
to
The
the
visco cannula is
Once
connected to
both
the irrigation
sutures are
probe.
out
It
of
is
the tunnel, the
brought out.
sutures
The
are
needle is passed
from
through the
above to
dialing hole
below
of the
through the dialing holes of the
intraocular
PMMA
lens, the
lens
PMMA,
and
regular
flanged
PMMA
until they
intraocular
are
lens,
larger than the
and the
goal
sutures
area.
are flanged
The IOL
till
is
it becomes
placed
larger
behind
than the
the iris
dialing hole
and the
itself.
sutures
The
from the
IOL is
sclera
interiorized,
held close to the
trimmed,
sclera,
flanged,
trimmed to
and
around
buried.
1.5 mm and flanged.
Similarly, the
Flanges
second
were
side is
by
also
lifting the surrounding
trimmed,
conjunctiva and tenons, while simultaneously trimmed to around 1.5
flanged,
mm
and
and
buried.
flanged.
So
It
the
is
same
as
procedure
simple
can be
as
done
can be performed with
with the
single-piece
foldable intraocular
IOLs
lens as
well.
well. So this is a case where the
Incisions
conjunctiva
on
is
both the
fibrous
sides.
because of the previous
The
retinal
needles are
surgery.
docked to an
So
irrigating
here,
cannula
90 degrees
and
away
brought
from the
out
clear
of the
corneal
clear
incision,
corneal
2
incision,
sclerotomies are
passing
done.
through the
The needle is
cartilage and
exteriorized
used to
through the
puncture the
clear
broad
corneal
base of the
incision.
IOL haptic
At the optic-haptic junction with the
on
same
both the
needle,
sides from
it is
above to
pierced.
below
The
before
sutures
flanging.
are trimmed,
The lens
flanged.
is then
It
loaded
is
and
loaded into
injected
a butterfly
the eye,
cartridge,
and
injected
the
into the
suture
eye.
sclerotomies are
The
pulled,
exteriorized
trimmed,
exteriorized
flanged, and
sutures
buried
are
to plug
pulled,
the
trimmed,
sclerotomies.
flanged, and buried. So these are my innovations with the flange technique. Thank you.
What suture are you using? Is it
So this is a needle and suture that we designed
10-0
exclusively.
proline?
It's a 7-0 proline.
7-0 proline.
Yes.
So do you think it is strong enough to hold on to the IOL and not pass through the opening you made in the sclera?
No, sir. So this needle, this is a needle that I designed. So this is a spatulated needle with 150 micron compared to the 26 gauge needle which we usually use for making the sclerotomies. That has a diameter of around 400 microns. Compared to this is half the size, and the incision is like a small slit. So the length of suture being flanged usually is 3 to 4 millimeters. Here it is just 1 millimeter.
And how long experience do you have? Follow-up of these
3
cases?
years.
3 years.
So the scleral fixation, iridodialysis repair, and we use the same thing to fixate capsular tension segment as well. But that has been done already, so we've not showed that here.
Okay.
Yes, sir. It's available with oral app.
And you showed fixation of a three-piece IOL. So, and you pass the suture through the whole of the IOL.
Yes.
So what happens to the loops? Do they remain like this? Don't they
We've done
irritate
some
the?
dry lab tests to test the strength of the flange compared to the regular knots, sir. These are more than twice stronger than the regular knots that we use for suturing.
No. I'm worried about the free-floating haptics of the PMMA haptics. Don't they irritate the ciliary
No,
body?
sir.
Or
We are
yeah?
actually positioning the IOL 2 millimeters behind the limbus. So they are not in contact with the ciliary body or the posterior surface of the iris. And the IOL power that we use is 0.5 diopters more than what we use as a PC IOL.
And what about the tilting of the IOL in such cases?
Sir, the advantage of fixating with the optic, dialing holes in the optic, is when we use a regular scleral fixated
Dr. Neeraj
IOL,
can
where
get
the
ready on the podium.
haptics have holes in it, there is a chance of tiltage. But here, the only chance is mild decentration if the first flange is a little too much. Only decentration we have seen, but we have not seen any tiltage so far.
So,
Thank you.
For the IOL, three-piece IOL, okay. For single-piece IOL, that bulky haptic is not rub against the
No, sir, it is posteriorly, it is behind the level of PC, 2 millimeters behind the limbus. Surprisingly, sir, very rarely you see iritis in these cases. We've done over 300 cases so far, and very, very few cases of iritis we've seen.
And in the market, there are single-piece IOLs available
you
with
spectrate.
so you don't have to puncture if you use those IOLs.
Yeah, now it is there, sir. The idea is to do with whatever we have. For a regular practitioner, on a day-to-day basis, it's difficult for us to have a stock of all those lenses. In case we are planning, we can get those. If we can do this as a primary and secondary procedure as well. So as a primary procedure, we want to do something, we can still
Dr.
do.
Neeraj,